Okay, we can start. So multiple sclerosis. So MS or multiple sclerosis is predominantly a white matter disease and a neurodegenerative disorder of the central nervous system that includes the brain, spinal cord, and the nerves. Okay. So as you can see here, this is one of the nerves. You can see the dendrite. You can see the myelin. Okay. So what happens is in multiple sclerosis, there is damage to the myelin sheath. Okay, here's the myelin sheath. You can see it's damaged, and we have said it affects the brain, spinal cord, and the peripheral nerves. Okay, as you can see here, this is a nerve fiber. Then this is a myelin sheath, and after a while, as I'm going to explain the pathophysiology, you'll notice that the myelin sheath gets damaged by antibodies. So it's an autoimmune disease. So it's an inflammatory and demyelinating disease. So from the word demyelinating, meaning that myelin is being destroyed. Inflammation, so the body's own immune cells attack the nervous system. And then demyelination, the myelin, which is this, the protective layer covering the nerves, is destroyed, leaving multiple areas of scar tissue or sclerosis. Okay, so what happens is when the myelin sheath is destroyed, it will leave things called plaques or sclerosis. Okay, it's a progressive disease, meaning as it starts, it tends to progress as the disease continues. Okay, most common age of occurrence between 20 to 40 years. So if you go to the ward, you'll see that a typical patient who gets multiple sclerosis is most likely female, aged between 20 to 40. Most of them will be around 25, 26, 24, 25, 26. Epidemiology, MS is commonly in Northern Europe, Northern USA, Southern Canada, New Zealand, Southwest Australia. Worldwide occurrence, 1.1 to 2.5 million cases, and then it is not contagious or communicable. The main peculiarities you'll see, MS affects women more than men in a ratio of 1.5 to 1. There are also some clinical differences in different localities. And then MS is predominantly a disease of young adults, as we had said, 20 to 40. Then this is a world distribution of MS. I want you guys to see the high-risk areas around here. This is the US and Europe, and then also here around Australia, New Zealand, and then we also have here Kenya. So Kenya, we are at low risk. You can see us here. So why do you guys think, or from this picture, what can you conclude, or what guess do you have to see that there is distribution of multiple sclerosis around these areas? What's your observation? You can type on the chat. Why isn't my multiple sclerosis common around these areas? Why is it common in these areas? Or what observation can you see? Because the observation you're going to see is going to be one of the risk factors associated with multiple sclerosis. Genetic predisposition. So do you mean whites get it more? Racial racial predisposition. I mean, people from the US are, I mean, there's whites and blacks. So no, it's not, it has nothing to do with race. Genetic, yes, it can be a factor, but what conclusion can you draw from this distribution of MS? Anyone wants to try? Cold climates, good. So what you'll notice is MS rarely affects people around the equator. So this is the equator, the 0 degrees. As you go away from the equator, that is towards the North Pole or towards the South Pole, you'll see that MS affects those people, okay? So we're going to see the risk factors of MS, and one of them is vitamin D deficiency. And we know that vitamin D is converted to its active form using sunlight. And that's why you'll see many people who have MS are away from the equator. Okay, so the colder climates. Then here are the risk factors. As we had said, the ratio of women to men was 1.5 or 2 to 1. If you have a parent or sibling with MS, you have a 1 to 3% chance of developing it. An identical twin with MS raises a risk to 30%. Then women with MS often experience relief from symptoms during pregnancy. However, about 20 to 40% of pregnant women with MS have a relapse within a few months of giving birth. Okay. Okay, that's something you have to note. And then people with type 1 diabetes, thyroid disease, or inflammatory bowel disease. So inflammatory bowel disease are like Crohn's and ulcerative colitis, have an increased risk of developing multiple sclerosis. So all these are autoimmune diseases. And then we have etiology. We have genetic susceptibility. So in genetic susceptibility, we have the HLA, human leukocyte antigens. There are specific HLA like the DR2, DRB1. Those ones have been shown with research that you have increased risk of getting MS. Then we have infections with viruses such as rubella, mumps, corona, parainfluenza, herpes simplex, EBV, human T lymphotrophic virus type 1. Okay. And then disbalance of steroid hormones. So estrogenic, as you can see, as we said, the predisposition is women are more likely to get MS than men. Then geographical, groundwater properties, other toxic or trauma. So geographical, as we had said, areas away from the equator due to insufficient intake. It can be due to insufficient intake of vitamin D or decreased exposure of sunlight. Okay. Okay. And then we can also add some other risk factors. For example, smoking. Smoking has been shown to be a risk factor, and obesity. Obesity is also a risk factor, especially obesity in early life. You see, if you're obese at 20 to 25, that's also a risk factor. Then for the pathophysiology, I think, let me draw so that you guys can understand. Okay. So you guys know the blood-brain barrier. So let's say this is the blood-brain barrier. So the blood-brain barrier separates, so blood-brain barrier. So we have the brain and then blood this side, okay? So here's the blood-brain barrier, the one in red here. So the blood-brain barrier prevents entrance of T cells into the nervous system, okay? So we know T cells can't be just roaming around the nervous system because they'll cause destruction of the nerves, the nervous system, isn't it? So the blood-brain barrier is normally not permeable to these types of cells, the T cells, unless triggered by an infection or virus, which decreases the integrity of the tight junctions. So in the blood-brain barrier, there are tight junctions here. But then if you get an infection, these tight junctions become more permeable. And when it becomes more permeable, the integrity is loosened. And what happens is T cells that are on this side of the blood-brain barrier go and enter the CNS, okay? So when the blood-brain barrier regains its integrity, usually after infection or a virus has cleared, the T cells are trapped inside the brain. So we have said the integrity has been loosened, the T cells have entered the central nervous system. So what happens is after the infection, your body has fought the infection and now you're getting better. What will happen is the T cells will be trapped inside the blood, inside the central nervous system. Now, autoimmunology. The immune system attacks the nervous system, forming plaques and lesions, okay? So what happens? The T cells are on this side of the CNS. And since they're trapped, they're going to go. So let's say, let me go to the previous picture. This is the myelin. So the T cells will come and start attacking the myelin sheath. And when we know T cells attack the myelin sheath, there'll be cytokines will be released. And these cytokines, you know, when an inflammation occurs, there'll be so many inflammatory cells that will be released. Cytokines, tumor necrosis factor, interleukin, all of those will be released. And when they're released, what will happen is the B cells will be targeted. The B cells will be called up, okay? When the B cells are called up, what happens is antibodies be produced. And when antibodies are produced, they now start targeting the myelin. They start destroying this myelin. And when this myelin is destroyed, remember there's something called oligodendrocytes. They're usually somewhere here. The role of the oligodendrocytes is to manufacture the, or to make the myelin sheath. So when these antibodies are attacking these, macrophages will come and engulf the oligodendrocytes, okay? So that's how it leads to the destruction of this myelin sheath due to that T cell. So it started from the T cell, then an immune reaction happened, and when it happened, what happened? The oligodendrocytes and the myelin sheath were destroyed. Okay, so have you understood that, the autoimmunology part? Then we have, so the immune system attacks the nervous system, forming plaques and lesions. So as we said, the more the myelin sheath is destroyed, the plaques are formed. So these plaques, we also call them sclerosis, okay? Commonly involves the white matter. We know the white matter is where myelin sheath is located. It destroys oligodendrocytes, causing demyelination. Remyelination occurs in early phase, but not completely. Repeated attacks leads to fewer remyelination. So remyelination is the process where the myelin sheath will try and heal itself, okay? So healing will start taking place. But as the disease progresses, remember we said that multiple sclerosis is involved with progression. It will not return to its original state, okay? So that's why we'll have repeated attacks. So the attack will come again, and then there'll be fewer remyelination. Then there'll be a stage of inflammation. So inflammation, the T cells attack the myelin, triggers inflammatory process, stimulating other immune cells and soluble factors like cytokines and antibodies. Leaks form in the blood-brain barrier, causing swelling, activation of macrophages, and more activation of cytokines and other destructive proteins, as I had explained, okay? Then I want to talk about the different types of multiple sclerosis. So this is very high yield. You should take note. Okay, so we have four main types. We have relapsing remitting, secondary progressive, primary progressive, and progressive relapsing. So the most common type of multiple sclerosis is relapsing remitting, or RRMS. Characteristics: short duration, days to months, may remain symptom-free for months or years, okay? So I have a graph here. So relapsing remitting is the one in blue. So we have, on the y-axis, we have disability. On the x-axis, we have time. So time is the lifespan, or the lifespan of the disease. So as the disease progresses, then disability is how much the disease has affected the individual. So if I were to explain, as you can see here, we have bouts of autoimmune attacks. So these are the bouts of autoimmune attacks. It rises, then it becomes steady, rises, steady, rises, steady, rises, okay? So as you can see from this, the time from one bout of autoimmune attack to the next, it can take from about months or even years, okay? But what you'll notice is the more the bouts of autoimmune attacks, the more disabling the disease is. So for example, as we're going to see, let's say the symptom is loss of vision or optic neuritis. So they'll have maybe pain on one eye or loss of vision. So you'll see here, you lose vision here. Then as it goes down, so this is where there's demyelination. And then as the graph goes down, the disability is reducing. So what is happening here is there is remyelination. So when remyelination happens, there will be improvement of vision, but your vision will not improve till where it was. You see, your vision started here. Let's give an arbitrary value. Let's say your vision was 6/6 here, but demyelination happened, then remyelination happened, then maybe your vision went to 6/9. Then demyelination happened again, then remyelination happened again, but this time, remember, your disability is worse. So if it was 6/9 here, it becomes, let's say, 6/12, then demyelination again, remyelination. It was 6/12 here, it becomes maybe 6/18 or 6/24. So as you can see, remyelination process will happen, but you'll still be more disabled than you were initially, okay? And the issue is this process will go on and on and on until you get loss of function, okay? So unfortunately, it's irreversible and there's nothing you can do, but there are some drugs we're going to use that will reduce this process. Remember, I've said this process, this time, it can either be months or years. So if you take your drugs properly, the bouts of attacks won't be that common, okay? That was relapsing, remitting. Have we understood that one? Now, the second type is secondary progressive or SPMS. So most of the 85% diagnosed with relapsing remitting will eventually transition to secondary progressive. So it is slow, steady progression with or without relapses. Relapses do not fully remit. Okay. So is that graph. So here, the one in what color is this? Orange. So you can see initially, it's similar to the relapsing remitting. As you can see, you get bouts, then remyelination, then another demyelination process, remyelination. But you can see over time, let's say this is around 6 or 7 years, the immune attack becomes constant, okay? So as you can see here, there'll be a steady progression of disability, as you can see here. So it started as the relapsing remitting, but it becomes constant, and then the disability just increases. So that's why we call it secondary progressive multiple sclerosis. I'm sorry. Then we have primary progressive multiple sclerosis or PPMS, steady worsening from the start, do not have periodic relapses and remissions. Okay. So it's the one in green. So it's one constant attack on the myelin, which causes a steady progression of disability over time. Can you see this? So as time goes on, you're just becoming disabled as time continues. Okay. And then we have progressive relapsing. So PRMS steadily worsens from the onset. Flare-ups with or without remission are also present, sorry. So we have the one in, is it pink? Can you see? So as you can see here, you're getting more disabled as time goes on, but it's a constant attack. You can see it's similar to the primary progressive, the one we said there's a constant attack, but here, as much as there is a constant attack, there are bouts of demyelination, remyelination, demyelination, remyelination, demyelination, remyelination, but the attack is constant. So you're getting disabled throughout, okay? And then the disability is very fast, as you can see, okay? So I hope you've understood the types or the patterns of multiple sclerosis. Then we go to signs and symptoms. The most common initial symptom, you'll see this from the words. From the words or anywhere you see, they'll tell you. So the most common initial symptom will be changes in sensation in the arms, legs, or face, optic neuritis, weakness, double vision, internuclear ophthalmoplegia, unsteadiness when walking, and balance problems. Okay. So normally with these patients, the earliest manifestation, okay, earliest is usually optic neuritis. Okay. It's usually optic neuritis. That's what I've seen in the wards. They'll come, they'll complain, oh, my eye is hurt, my eye is hurting. And it's usually unilateral. Okay. They'll tell you, oh, it's a right eye or the left eye. And it can be very, very painful. And then they can tell you, oh, I can't see with that eye, or maybe I'm seeing double vision, diplopia, or I can't tell the color, or I'm seeing dark in the center, then I can only see on the periphery. Okay. So optic neuritis usually varies from individual to individual. Okay. So one thing I want you guys to notice is in these symptoms of multiple sclerosis is the reasons why we have these symptoms is, remember we said on the pathophysiology, plaques are being formed where the myelin sheath are being destroyed, isn't it? So, for example, in the optic neuritis, in a patient with optic neuritis, there'll be plaques at the optic nerve. In a patient with loss of sensation in the arms, legs, or face, meaning there are plaques that are being formed in the nerves that are supplying these areas. If you're having weakness, plaques on the area of weakness. If you're having bowel, incontinence, diarrhea, or constipation, you're having plaques at the autonomic nervous system, okay? So the symptoms are based on where these plaques are being formed, okay? So that is something you should note. I can see this man. So visual changes, you can have nystagmus. We know nystagmus is the rapid movement, eye movement, can either be horizontal or vertical. Optic neuritis, diplopia or double vision. Then speech, you can have something called dysarthria. So dysarthria is where you cannot form words properly. You cannot pronounce words properly. So this is when you have plaques maybe in the brainstem. So a specific nerve that innervates the muscles of the mouth that cause phonation are what is affected. Then you can have dysphagia. The vagus nerve is affected. Musculoskeletal, you can have weakness, spasms, or ataxia. Sensation to pain, hypoesthesia, paresthesia, then urinary, as you can see. So the main thing is all these neurological symptoms are due to plaques. That is what is the take home. Then there are two signs I want you guys to know. We have one called Lamiti sign and Athoff sign phenomenon. Lamentier sign, an electric sensation that runs down the back and into the limbs and is produced by bending the neck forwards. The sign suggests a lesion of the dorsal columns of the cervical cord or the caudal medulla. Okay, so they'll tell you they had an electric shock when they bend forward, bending the neck forward. The shock, an electric shock goes down their back. That's Lamenti sign. Then we have Ufthoff's phenomenon, worsening of neurological symptoms in multiple sclerosis and other neurological demyelinating condition when the body gets overheated from hot weather, exercise, fever, or saunas or hot tubs. Okay, so they'll tell you, oh, when I shower in the morning with hot water, my symptoms worsen. Okay, so that's the Ufthoff's phenomenon. Or if I go to a jacuzzi or a sauna. Okay. Then these are the clinical manifestations. I had mentioned them. Retrobulbar neuritis, disturbance in ocular motility. So they'll tell you they usually have pain. So if they tell you if they have pain on movement of the eye, you know that plaques have formed on the oculomotor nerve or the nerves that are supplying the extraocular muscles. Lemaitre sign, the electric shock, pyramidal tract sign, cerebellar signs. So they'll have issues with ataxia or gait impairment, sensory deficits, bladder dysfunction, ictal phenomenon, mental disturbances. So there's something, before I go on to this, there's something called the Charcot's neurological triad. So Charcot has many triads. So there's one called Charcot triad for acute cholangitis, which is fever, jaundice, and right upper quadrant pain. But for Charcot's neurological triad, we have dysarthria, intention tremors, and nystagmus. Okay? Dysarthria, intention tremors. So intention tremors are caused by plaques that form on the motor pathway. Okay? And then we have the last one is nystagmus. Dysarthria, intention tremors, and nystagmus. Retrobulbar neuritis, usually unilateral. Patient develops impairment in color vision. So this is something, not all patients will come with impairment in color vision, but some will. So the patient I remember at Clark, they told me they started seeing white, then it went to gray, then it went to black. Then she became blind. That was how the color vision progressed. Some will tell you this, it started with red, then it appeared pinkish or orange, pink, then it went dark. Okay. Impairment of visual acuity, finger counting is barely possible. So as I said, you remember the vision basically becomes blurry. Orbital pain is often present, able to see flashes of light on movement of globe. The temporal side of the optic disc becomes pale 3 to 4 weeks. Retrobulbar neuritis rarely affects both eyes either at the same time, okay? So you have to know optic neuritis for multiple sclerosis is usually unilateral, okay? Then one thing I remember is when doing fundoscopy, okay, as you can see here, the optic neuritis is inflamed here. We have said it becomes pale after 3 to 4 weeks. So you'll see sometimes when the patient comes to you, they've had, let's say, a 1-week history of eye pain. And then when you do fundoscopy, it might be normal. But the patient will still tell you they cannot see. So funny thing is, neither you, who's the doctor, nor the patient can see anything. You won't see anything on fundoscopy, and the patient cannot see anything when you do a cranial nerve 2 exam, okay? Then disturbances in ocular motility. This is when the plaques have formed on the oculomotor nerve or the abducens nerve. So diplopia is particularly due to abducens nerve palsy, is a common early symptom, nystagmus, and then intranuclear ophthalmoplegia. So intranuclear ophthalmoplegia in a young patient is relatively specific for multiple sclerosis. This condition is caused by lesion in the MLF, the medial longitudinal fasciculus. This is one of the nuclei that are found in the midbrain, if you can remember your anatomy. So what happens is, so let's take okay, let me explain. So in medial longitudinal fasciculus, if it is affected, they'll be unable to adduct this eye. So if the right one is affected, so this is the right eye, they'll be unable to adduct. They cannot move their eye this side. So when they try, if it was here, you can see this eye has adducted here, but look at this one, okay? So in the initial phase of the leftward gaze, upper photograph, only the left eye is abducted. So they're turning this side, but this eye won't be able to adduct. The right eye follows after a delay. So after a while, it's when they'll be able to adduct, okay? Pyramidal tract signs are exaggerated intrinsic muscle reflexes, may be present early in the course of the disease. Abdominal cutaneous reflexes are absent. Then spastic paraparesis or quadriparesis develops. Then you have motor disturbances like central paresis, spasticity, or abnormal fatigability. Cerebral signs present in advanced MS, impaired coordination, ataxia, and frequently a very characteristic intention tremor. Okay? Okay, you can see this spastic gait. Then gait impairment, severe, early in the course of the disease. Spastic paresis and ataxia results in spastic ataxic, uneven and coordinated and stiff gait. Normally not see this in a patient because it usually develops later in the disease, okay? Then MS degrees. So degree 1, patient has difficulty to walk only after physical training. Degree 2, patient has difficulty to walk and weaknesses on 2 to 3 kilometers. Degree 3, patient has spastic paralytic gait, difficulty to walk and weakness on 200 to 300 meters. Degree 4, cannot walk without help, cannot walk or has blindness. So the worse the degree. So degree 5, the worse the number, the worse the degree. Then for differential diagnosis, so these are the things you should rule out when taking your history. You can remember the formula for vitamin C, D, E, vascular, infections, trauma, autoimmune, metabolic, iatrogenic, neoplastic, congenital, drugs or degenerative, and then endocrine. So metabolic, we have subacute, what is the name? SCD for vitamin B12 deficiency. We have adrenomyeloneuropathy, though this one, you won't really get it. So the SCD is subacute combined degeneration of the spinal cord. That's due to vitamin B12 deficiency. Then connective tissue diseases, we have Sjogren's, which is where you have, you're unable to produce, what do you call it? Fluids. So it's usually characterized by dry eyes, dry mucosas. So they can't cry, they have dry lips, and then they have dry, anywhere you have a fluid, so even dry vagina. So they usually have itchy. Then we have SLE, itchy vaginas. Then we have SLE. Infectious, we have HIV, human T lymphocyte virus 1, Lyme disease, syphilis. Structural, so these are the congenital ones. Chiari malformation, spinal cord compression, genetic ataxias, paraplegia, mitochondrial diseases. Neoplastic, we have CNS lymphoma, paraneoplastic. And then in quotes, MS variants. So N, which is the optic neuritis. TM is transverse myelitis, which I'm sure you're going to do when you're going to do Guillain-Barré syndrome. They're going to mention transverse myelitis. Then ADEM, which is acute disseminated encephalomyelitis, and then NMO, neuromyelitis optica. These ones are actually rare. You're not going to see them. I've only seen one case of neuromyelitis optica, but yeah, I've only seen one case during my time in Clarking. And then neurosarcoidosis, and then CNS vasculitis. Then it can also be psychiatric. So why they're saying psychiatric? Because patients with MS can have psychiatric symptoms. For example, they can have depression. Okay. Well, then we go to investigations. We have in the CSF, blood test and MRI. One thing to mention is MRI is the gold standard, okay, for diagnosing MS. On CSF, you're going to see oligoclonal bands, abnormal colloidal gold curve, elevated gamma IgG, mild mononuclear pleocytosis, myelin debris, normal or slightly elevated protein. The main thing to know in CSF, you're going to have increased IgG levels and oligoclonal bands in CSF levels. Then for blood tests, we do this to rule out. So for example, you're going to do B12 and folate levels to rule out subacute combined degeneration of the spinal cord caused by B12, or anti-nuclear antibodies titers due to the autoimmune diseases. Then antiphospholipid antibody syndrome may be undertaken in patients with evidence of blood dyscrasias and in women with unexplained miscarriages or history of deep venous thrombosis. Okay, so this is the autoimmune one. Elevation of ESR and positive titers of rheumatoid factor should help identify the presence of vasculitic disorders that may be mimicking MS. So blood tests, this is used as to rule out other causes of such symptoms. Then MRI, as I had said, MRI is the gold standard for diagnosis of MS. MRI of the head and the spine, more sensitive than CT, may show many plaques. Remember the plaques or the sclerosis we had said that are formed due to damage of the myelin sheath. So MRI reveals multiple lesions with high T2 weighted signal intensity and one large white matter lesion. These demyelinating lesions may sometimes mimic brain tumors because of the associated edema and inflammation. So I want to show you guys a picture. I don't know if it's clear. So these are the plaques, these white areas. as we said, they are found in the white matter. Okay. Can you see them? So this is a healthy brain. This image is this. So then here are the plaques. Usually brain damage, lesions with plaques caused by MS. They're usually periventricular, meaning they surround the ventricles. Okay. And then we have something called Dawson's finger. Is the name of the multiple sclerotic lesions around the ventricle-based brain veins of multiple sclerosis or patients seen in MRI. Can you see these ones? These are the Dawson fingers, very specific for multiple sclerosis. Okay. Okay. Management. We usually do steroids for an acute attack. So if a patient comes in with optic neuritis, they tell you, oh, my eye is paining, we do IV steroids, okay? Methylprednisolone, IV for 5 days, followed by tapered oral prednisolone. So taper is reducing the dose. We do oral prednisolone for 3 days. So management is not really your topic, but just to know, you'll hear them during rounds. They usually say, taper it, they do corticosteroids, but that's for an acute attack. But we need to slow progression of this disease, isn't it? So there are some drugs we use, interferon beta, 1 alpha, 1 beta, glatiramer acetate, methoxanotrin, natalizumab, fligolimod. Okay, so the most common I've heard is natalizumab. It's the one that's used to reduce progression, cannot reduce, but to stop, to slow down the progression and to stop relapses. Okay. And then here's the treatment. So we do symptom specific. So difficulty in walking, you give dalfimipride, muscle spasticity, yeah, baclofen. And then eye problems, we do the corticosteroids, fatigue, emotional outbursts, you can give antidepressants. Pain, we do the NSAIDs, bladder dysfunction, antibiotics, vitamin C, sexual dysfunction in men, you give Viagra, sildenafil, tadalafil, and then tremors, often resistant to treatments, sometimes drugs or surgery, often tremors are severe. Yes, I'm done. Do you have any questions?